Hi, this is case of the day, and today is the 98th case. And if everything goes to plan, we should be doing the 100th on Wednesday. This is a 16-year-old who presented with fever and neck pain. An MR was done, and we can see here the C6 vertebral body is collapsed. There is T1 marrow change in the C5 and C7, little bit of a bright disc, perivertebral and anterior epidural soft tissue, and the bright disk is very well seen on the stir and the T2. And while there may be other possibilities, this pattern of disease is most commonly seen with an infectious spondylitis. And this lecture is there. I think I put this up about 2 or 3 weeks ago. And it covers all of these issues as to why this particular pattern would be infection. So the patient was referred for a CT guided biopsy, and I did a plain low dose CT from skull base to pelvis just to see if there was any other lesion to biopsy, which would then yield more tissue. And I covered this in case 69, where I talked about why that was so important and relevant. Though I finally did land up doing the CVJ biopsy, this patient had an iliac bone lesion, which we hadn't done the whole body and picked it up in detail at the time. But this patient had no other lesion. And so I did a contrast enhanced CT to identify all the vessels, at which time I saw that this was a perivertebral collection. There was calcification, and this pattern not only is suggestive of infection, it is suggestive of, it's typically seen with tuberculosis. Now, cervical spine biopsy approaches are all of these here. And in our patient, I had two options. One was the transthyroid, which would have gone into the collection, but it would have been tough to then change trajectory and go into the body. So this was a little limiting, and I thought a good idea would be to go retrocarotid in front of the anterior jugular, behind the internal jugular, in front of the vertebral, first hit the collection, and then if I didn't get frank pus, go into the vertebral body. And this retrocarotid approach I discussed in case 56. You can go through that if you're interested. So I used an 18 gauge barred short, that's the 5 centimeters needle length. And I was going to use the hub to restrict my throw length. And here you can see that I'm just behind the internal jugular vein. So the head is rotated a little to the left, which is why now the carotid vessels are a little more medial, which helps create more space between the anterior jugular vein and the internal jugular vein. I'd given contrast at the time as well, and now I'm going behind the internal jugular. Here I used a blunt tip as well, just to make sure that I wasn't penetrating vessel. I've talked about the blunt tip earlier with mesenteric and biopsies and abdominal biopsies where you want to avoid bowel. I went into the collection, but I aspirated, but I didn't get pus. And here it is one more attempt to do that. And then I just straight went into the vertebral body, deployed the gun, and biopsied it. So there was no, despite the fact that there are air foci here, unfortunately this was a very thick caseous material, I guess, and I didn't get any pus using the 18 gauge. This is the summary. It took about 20 minutes to do this. The patient was completely sedated, and I got 2 calls for histopath and 3 for micro. The report came today. It was gene expert positive for MTB. Rifampicin resistance was detected. So cervical spine lesions are usually approachable using some route or the other, and safe as long as we keep in mind anatomic principles and the positions of the vessels and major nerves. And we should liberally use intravenous contrast to identify the vessels. And also with cervical spine lesions that seem a little tricky. But the whole idea is to get as much material as possible. And so it's a good idea to scan the entire spine. And I'll talk about this in the next 2 or 3 cases once the result of a biopsy that I did today comes out, to show you that particular principle again. That's the seminar we're doing on October, my WhatsApp channel, and thank you so much for viewing this.